Thank you for inviting me to talk today, guys. I'm going to be presenting some data from my PhD, which focused on the association between smoking cessation, and mental health. If you have any questions throughout, just shout out, and then I've got some discussion points for the end as well. So just a bit of background into the area. Most smokers want to stop smoking. Survey data from lots of different countries suggests that about 75% of smokers want to stop. However, many smokers continue smoking because they feel that smoking offers psychological benefits. So this could be things like relief from stress or relief from feelings of anxiety or low mood. However, there's a really strong association between smoking and poor mood or much more likely to smoke. And a recent report showed that about 2/3 of smokers show some evidence of a mental health problem. So there's three hypotheses which aim to explain this association. The first hypothesis is the misattribution hypothesis, and this suggests that smoking leads to poor mental health. And this is thought to occur through neuroadaptations in sort of mood regions of the brain. And this sort of occurs through the nicotine withdrawal cycle. And the misattribution hypothesis also suggests that after smoking cessation, mood will improve or mental health will improve. The next hypothesis is the self-medication hypothesis, and this suggests that smokers use the chemical process, mental health will worsen. Mental health will worsen because the person can no longer use the medicinal properties from tobacco. And the next hypothesis is the common cause hypothesis, and this suggests that a third factor causes both the co-occurrence of smoking and poor mental health, and that neither smoking or mental health will change unless this third factor changes first. So for my PhD, I aim to examine the association between smoking cessation and change in mental health using observational data. And I'm going to show you two studies today. The first one's a systematic review. So my first study was published at the beginning of this year, and if you work in smoking research, you'll recognize a few of the names on this paper. So thanks to the team that I worked with. And the systematic review and meta-analysis, we aim to examine the difference in change in mood between people who stopped smoking and people who continued smoking. And that was from baseline to follow-ups greater than 6 weeks. So the systematic review, we included longitudinal studies of adults in any population and any language inventories. And we excluded studies which measured follow-up during the withdrawal period, and that's because we know 5 to 6 weeks after cessation, people are likely to experience withdrawal symptoms like low mood and anxiety. And so for the meta-analysis, we used a generic inverse variance meta-analysis of the standardized mean difference and change, and we used a random effects model. So that's quite fancy terminology just to say that the studies we included were different in some way or another, and we statistically accounted for that. So here's the flow of records, and you can see we retrieved just over 13,000 records, and we narrowed this down to 26 for meta-analysis. In total, the studies included just over 17,000 participants. We had 6 outcomes there, so anxiety, depression, and follow-ups range. And follow-ups range from 7 weeks to 8 years. Most studies were of good to excellent quality, and we assessed those using the Newcastle-Ottawa scale. And we included 3 different study types, which all reported longitudinal studies of the groups. So I'm only going to show one forest plot, and that's because they all show the same pattern of results. So if you look here, okay, so on this side of the plot, you can see that the mean difference in the confidence intervals all favor the quit group. We had one study at the top here, Solomon, which I'll get to in a moment. And so you can see here that it's statistically significant, and the effect size right here, that falls in between that's the small to medium effect size range. So a lot of you guys are from psychology, so you might be more familiar with Cohen's d. No, yes, no, yeah. So this is a measure that's Cohen's d, pretty much. Okay. So what the forest plots don't change is, or sorry, what they don't show is the change between groups. So what's happening for people who quit smoking, what's happening for people who continue smoking. So for studies which provided us with all the patients' data at baseline and follow-up, we combined these studies' data and we looked at the change in the groups over time. Outcomes. And this was the same for sort of the more positive affect scales here. So for psychological quality of life and positive affect as well, people who quit smoking showed an improvement, and people who continued stayed about the same. So we conducted multiple sensitivity analyses to see if the effect estimates were altered by removing studies or by comparing studies with characteristics which may have introduced bias into the association. So we compared effect estimates between the clinical populations, and we had no showed very little change, whereas the rest of the population actually showed quite a significant change, which is quite interesting. If you do any research into pregnant smokers, I can show you that data later on. But what was quite important and what we were interested in was whether or not the psychiatric population, what happened to their mental health. And then this showed an improvement in mood associated with quitting, and this was comparable to the general population and the other populations, so those with chronic physical conditions. And we looked into a lot of other different things here, and I can go into those details in detail later, to be associated with smoking or mental health. And we found no significant association here except for the outcome of anxiety. So studies which adjusted for covariates found a larger effect estimate, and that may not have actually been because of confounding, because we had 4 studies that provided unadjusted estimates and 1 study which provided an adjusted estimate. And that study is actually this one at the bottom here, 3 to dot 4. But this is another comparison we did. So like I said before, sort of one of the biggest threats to observational data is the possibility of confounding. So studies which provided us with both adjusted and unadjusted estimates of the same data, we compared the estimates here, and you can see that they don't differ very much. So in the case of these variables that they've adjusted for, which are just over here, it's unlikely that these had much effect or much influence on the association. So another issue using observational data is the possibility of reverse causality. So you can never completely rule it out, a causal argument. So the first type of study we included was population cohorts, and in these studies, it's really, really hard to rule out reverse causation. The next type of study, there was one study where people actually randomized to quit or to continue smoking, and they did manage to get a follow-up at 3 months. And in this study where people were randomized to quit or to continue, people who quit smoking did show a moderate improvement they had depression and anxiety outcomes for the quit group. It wasn't statistically significant, but the study was underpowered. So the next type of studies that we included were observational analyses of data from cessation trials. And these, although they appear to be like a normal cohort study, they're not, because in these studies, everybody signed up to try and quit smoking. So in these studies, everybody quit at baseline at the same time that there remained there, but we didn't. The change was observed here. So although this doesn't completely rule out reverse causation, we argued that it sort of strengthens the causal pathway. So if it is causal, and again, I'm not saying it is because you cannot be completely sure, but we compared the effect estimates of stopping smoking versus continuing smoking to effect estimates of antidepressant treatment versus placebo. And what we found is that the effect estimates for stopping smoking versus continuing are equal or larger to the effect estimates for antidepressant treatment. And these estimates for the antidepressant treatment for anxiety, that one, lots of data from depression trials. So in conclusion, for that study, so smoking cessation is associated with improved mental health. If it is causal, the association appears to be clinically important. However, there's the risk of unmeasured confounding, and also it's at risk of group membership bias. So are there systematic differences between people who quit and continue smoking? And that leads me to my next study, which we did an exploratory analysis. So just a bit of background to this study. So there's quite a likelihood that the ability to achieve cessation actually undermines the RCT design. So I mentioned earlier that there was one trial that actually randomized people to quit and to continue smoking. But in this trial, only 20% of people who were randomized to quit stayed quit, and 20% of people who were randomized to continue smoking actually quit smoking. So there's some systematic differences between the groups, and it almost seems that they just sort of do what they want to do. So this differential attrition undermines any effect estimate you get from a randomized design. So that's one issue. The second issue is unmeasured confounding, and propensity score matching is a technique that can be used to overcome these issues. So what's propensity achieving abstinence? Abstinence based upon their observed baseline covariates. And in theory, if you match people on as much covariates as you can, assuming those covariates are correlated with other things, you also can account for some unmeasured confounding. And if you get a good match between the groups, you can, in theory, make a causal estimate. So just a comparison of the models or of the techniques here. So I'm not saying that one model is better than the other. What I'm saying is that they both offer sort of different ways to adjust for confounding and reverse causation, or sorry, just confounding, and that actually sometimes these methods may be used, better used sort of to complement each other. Association with exposure only, so you don't consider the outcome when you develop a propensity score. And in a regression model, unmeasured confounding is an issue, but as I just explained, in a propensity score model, there's more control for unmeasured confounding. However, a regression model, one of the biggest benefits here compared to propensity score matching is that you can use most of your data set. Whereas in a propensity score, you're always going to be using just a proportion of your data set. So for example, if you have a data set of 1,000 people and you have 100 people who stopped smoking, you can only then go and match those to another 100 people who continued smoking each population. So in this study, we used linear regression modeling to compare the difference in change in mental health between quitters and continuing smokers. So if this study was done before the meta-analysis, it would have been included in it. So we're assessing the exact same association. And then we aim to match quitters and smokers on their propensity scores and repeat the model in the match sample. And then we wanted to see if the strength or direction of the association differed between the two models. With data from 5 trials of NRT for smoking reduction. And in these trials, people recorded their mental health and smoking status at multiple follow-ups. And then we used, that's a lot of fancy terminology about the propensity score matching technique, but basically it means we matched one quitter to one smoker, and we matched people with the closest propensity scores first, and we matched them within the overlap of the distribution. So if you imagine two again. So just a little diagram here, again, of what we measured. So the difference in change between people who quit and continued, and people were reported quits at 6 and both 12 months. So you can see the baseline characteristics here. We didn't have any demographic data to make sure that all the data remained anonymous. The company couldn't send us that information. But anyway, so the groups differed significantly on nicotine dependency and treatment status. So people who quit were less dependent and more likely to have received. We looked at the change scores here. So people who quit showed an improvement in scores. People who continued smoking stayed about the same. And because you can never be sure when you use sort of within person repeated measures data is always the chance of regression to the mean. So we didn't compare the difference in change in these scores. We put the outcome into the regression model and then adjusted for the baseline. So mathematically it's the same as a change, it just sort of stops the overestimation of any effects. So the unadjusted estimate, although adjusted for baseline mental health, shows a significant effect there in that people who stopped smoking showed an improvement. People who continued smoking, they stayed the same as that showed. And then after adjustment for NRT, age, sex, trial country, and nicotine dependency, it's reduced slightly, but it still stayed significant. So the next thing we did was develop the propensity scores for the group. And again, to do this, we use a logistic regression model to fit the scores. Sort of more likely to quit or to continue. And these are just some of the things that we've put into the propensity scores. We tested about 30 different sort of behavioral and psychological covariates, and these were the ones that came up statistically significant. We matched people within trials, so depending on the trial, they could have been matched on a different combination of these covariates on their mental health. So mental health predicted their ability to quit as well. And so in the match sample, you can see our sample size is greatly reduced, but we achieved a balance, which is the whole point of propensity score matching. There's no longer any systematic differences between the groups. But we lost 8 quitters there. So what that means is that in that quit group, there were 8 people that have propensity scores that couldn't be matched to anyone in the smoking group. That's quite in the match sample. It followed the same pattern. It's just one of the lines is shifted a bit. So people who quit showed improvement, and smokers showed little change. And the association is no longer significant. However, the direction's not changed. An adjustment for age and sex didn't change that. So in conclusion, just a few limitations. So in this study, reverse causation is quite possible. It was a small sample size, and we didn't have any demographic data. The scores didn't include as many variables as in and also we didn't look at any interactions between covariates, but we were already having problems fitting the regression models because the sample size was so small. And again, I mentioned earlier, potentially there's bias through changing the population. So in conclusion, regression modeling, it offers more power, however, there's a higher risk of confounding and bias. And propensity score matching has less power, but it offers more control for confounding and bias. So there's sort of a question, which method really offers more accuracy? And I sort of have concluded that in this study, most of the associations So in discussion, so sort of talking about both the studies in combination, and we used means in both of these studies, and this may actually conceal rare occurrences of any psychological offset effects. So there's a guy called John Hughes who works in the States, and he proposed a theory that when some people quit smoking, their mental health actually worsens. So they get an offset effect from a withdrawal effect. So a withdrawal effect from tobacco is something like low mood, and he suggests that in some people this low mood is permanent. So they have an offset effect of some sort of mental health disorder. And if this occurred, it would have been concealed by the use of, and this may have explained some of the associations we saw here. So whoever improves stays quit, but whoever worsens, well, they just go back to smoking and go back to their normal level of mental health. We can't really rule out common cause, so there could be something that causes both stopping smoking and improved mood here. I don't know what it could be, so if you guys have any suggestions, I'd like to know, because there's a few sort of things that it would have to have. So in the meta-analysis, it occurred in lots of different populations. It occurred at lots of different time points. So our follow-ups ranged from 6 weeks to 8 years. So it would have to maintain some sort of consistent chronological effects. And also in the prospective analysis, although it was a small sample size, the trials were conducted across countries. So it would have had to have occurred across countries as well. So if you guys have any suggestions, let me know. Cessation on average is not associated with psychological harm, and this is particularly important when working with psychiatric populations. A lot of, not all clinicians, but a subgroup of clinicians avoid addressing cessation in people with mental health problems because they fear that it could actually worsen their condition. This data doesn't show any evidence for that. If there is a causal pathway, it's supported by some biological evidence. So if chronic exposure to tobacco causes sort of neuroadaptations in mood regions, there's some data to show that these pathways return to a normal level of functioning at about 5 weeks of sustained cessation, which is the same time people and there's lots of data showing complete opposite from what these studies are showing, and also lots of data that show that there's beneficial effects from tobacco as well. We're just not quite sure how long those effects last. So thank you very much for listening to our presentation, and thanks to these. Thank you.